What is the significance of the fact that the human trachea is reinforced with cartilage rings? Our answer: the trachea's cartilage rings strengthen the trachea walls, keeping the airway open independent of pressure fluctuations while breathing. Of the fact that the rings are incomplete posteriorly. When big chunks of food are eaten, the open portions of these cartilage rings allow the esophagus to expand anteriorly. Name the specific cartilages in the larynx that described below. For the first one, forms the Adam's apple, our answer, thyroid cartilage. For the second one, a lead for the larynx, our answer, epiglottis or elastic cartilage. For the last one, broader anteriorly, coracoid cartilage. Chase a molecule of oxygen from the nostrils to the pulmonary capillaries of the lungs. Our answer: nostrils, nasal cavity, to pharynx, to larynx, to trachea, to primary bronchus, to secondary bronchi, to tertiary bronchi, to bronchiole, to respiratory bronchiole, to alveolar duct, to alveolar struct, to alveolar or capillary walls, and lastly to pulmonary capillaries. What is the function of pleural membranes? Pleural membranes generate lubricating serous fluid, which causes them to cling tightly to one another, anchoring the lungs to the thoracic wall, but enabling them to move freely against one another. The two functions of the nasal cavity mucosa, our answer: it warms, moistens, and filters the air passing through the nasal cavity. The longer one is the left main bronchus. The larger in diameter is the right main bronchus. The more horizontal one is the left main bronchus. The more common site where a foreign object that has entered the respiratory passageways is likely to become lodged, our answer is right main bronchus.
Thank you, Miss Gonzaga. Hi everyone, I am Zon Khyze Japay and I will be reporting the item number 8 to 13 of Test 1, Anatomy of the Respiratory System. For item number 8, correctly label all structures provided with leader lines of the diagrams that is shown on the screen. First label will be the trachea, or also known as the windpipe. It is a tube about 4 inches long and less than an inch in diameter in most people. Trachea divides into two smaller tubes called bronchus. These are two large tubes that carry air from your windpipe to your lungs. It is followed by the first subdivision of the main bronchus called the lobar or secondary bronchus and ends as terminal and respiratory bronchioles called the segmental or tertiary bronchus. The air proceeds to the terminal branches or bronchioles, the distal bronchioles that do not bear alveoli. Each terminal bronchiole and its branches constitutes a lung acinus. Terminal bronchioles become respiratory bronchioles when cilia starts to disappear and alveoli start to bud off. Alveolar ducts are the tiny end ducts of the branching airways that fill the lungs. This is also where blood exchange oxygen and carbon dioxide during the process of breathing. Alveolar sacs are tiny air sacs at the end of the bronchioles. Let's proceed to item number 9, the matching type. Number 1, pleural layer covering the lung tissue, visceral pleura. Number 2, floor of the nasal cavity, palate. Number 3, food and fluid passageway inferior to the laryngopharynx, esophagus. 4. Flaps over the glottis during swallowing of food, epiglottis. 5. Contains the vocal cords, larynx. 6. The part of the conducting pathway between the larynx and the primary bronchi, trachea. 7. Pleural layer lining the walls of the thorax, parietal pleura. 8. Site from which oxygen enters the pulmonary blood, alveolus. 9. Opening between the vocal folds, glottis. 10. Increases air turbulence in the nasal cavity, concha. Let's proceed to item 10. Define external respiration and internal respiration. External respiration refers to the gas exchange across the respiratory membrane of lungs. Internal respiration refers to the gas exchange across the respiratory membrane in the metabolizing tissues. For item number 11, demonstrating lung inflation in a sheep flock. Question: does the lung inflate part by part or as a whole like a balloon? Our answer will be because of the partial pressure of oxygen is greater in the alveoli, therefore it moves according to the laws of diffusion into the pulmonary blood. Next question: what happened when the pressure was released? Our answer will be as the diaphragm and intercostal muscles relax, the lungs and the thoracic tissue recoil and the volume of the lungs decreases. This causes the pressure within the lungs to increase about that of the atmosphere, causing air to leave the lungs. Last question for item number 11. What type of tissue ensures this phenomenon? Our answer will be the lungs also contain elastic tissues that allow them to inflate and deflate without losing shape and are encased by a thin lining called the pleura. This network of alveoli, bronchioles, and bronchi is known as the bronchial tree. Let's proceed to item number 12. Examining prepared slides of lung and tracheal tissue. The tracheal epithelium is ciliated and has goblet cells. What is the function of each of these modifications? Our answer will be the cilia push mucus and dust off of the lungs. The goblet cells produce mucus. Let's proceed to item number 13. The tracheal epithelium is said to be pseudostratified, and why? Our answer will be all of the cells of the pseudostratified epithelium rest on the basement membrane. However, some of its cells are shorter than others, and their nuclei appear at different heights. As a result, the epithelium gives a false impression that it is stratified. And that would be all. Let's proceed to
First of all, good day everyone. I am Gato and I will be the one who will present our answers for the number 14 to 16. So, for number 14, on the diagram below, identify the alveolar epithelium capillary endothelium, alveoli, and red blood cells bracket the respiratory membrane. So first, I will tackle about the upper part, yung mga nasa taas na lines. So in the right side, the first line in the right side, upper, our answer is alveolar epithelium. It represents a physical barrier that protects from environmental insult by segregating inhaled foreign agent and regulating water and ion transport. And the next is, our answer is capillary endothelium. It is the thin wafer-like cell joined at their borders and form the inner lining of the entire blood vascular system. So the next one in the upper part, left side, our answer is red blood cells, which carry the oxygen from the lungs to all parts of the body. And the next is the first line in the left side. Our answer is capillary endothelium, which again, the thin wafer-like cells. The next second line in the left side, our answer is the basement membrane. It is a thin, pliable sheet-like type of extracellular matrix that provides cell and tissue support and acts as a platform for complex signaling. And the next line, or the last line, the left side, is our answer is alveolar epithelium, which is represent a physical barrier that protects from the environmental insult. And for the middle or the central part, our answer is alveoli. It is where the lungs and the blood exchange oxygen and carbon dioxide during the process of breathing in and breathing out. For number 15, why does oxygen move from the alveoli into the pulmonary capillary blood? Our answer is, it is because the partial pressure of oxygen in the alveoli is higher than the pulmonary capillary blood. As a result, oxygen diffuses from the alveoli into the pulmonary capillary blood. And for number 16, what structural characteristic of the alveoli makes them an ideal site for the diffusion of gases? Our answer is thin walls and extremely large surface area.
Good day everyone, I'm Tanya, Garcia, and I'm going to discuss our answers in respiratory system physiology. Mechanics of respiration. Number 1. Base your answers to the following on your observation of the operation of the model lung. Under what internal condition does air tend to flow out into the lung? Our answer is increased thoracic volume and decreased pressure. Under what internal condition does air tend to flow out of the lung? Explain. Decrease in thoracic volume, increase in pressure. Gases move in a direction that tends to equalize pressure inside and outside of the container. Number 2. Activation of the diaphragm and the external intercostal muscle begin inspiratory process. What results from the contraction of this muscle and how is this accomplished? Increased thoracic volume. The diaphragm moves inferiorly, increasing the superior-inferior dimension. The ribs swing up and out, increasing the lateral and anterior or posterior dimension. Number 3. What was the approximate increase in diameter of chest circumference during a quiet inspiration? Our answer 1/3/6 inches. During forced inspiration, our answer is 3/15/16 inches. What temporary physiological advantage does the substantial increase in chest circumference during forced inspiration create? Increases the thoracic volume move, therefore creates a greater negative internal pressure, causing the gases to rush in quickly. Also move fresh air reaches the alveoli. Number 4. The presence of a partial vacuum between the pleural membranes is necessary for proper inflammation of the lungs. What would occur if an opening were made in the chest, as with a puncture wound? Destroys the partial vacuum in the pleural space and the lung on the affected side collapse. Respiratory volumes and capacity spirometry. Number 5. Write the respiratory volume term and the normal value that is described by the following statements. Volume of air present in the lungs after a forceful expiration. Our answer is residual volume 1,100 ml. Volume of air that can be expired forcibly after a normal expiration. Our answer is expiratory reserve 1,200 ml. Volume of air that is breathed in and out during a normal respiration. Our answer is tidal volume 500 ml. Volume of air that can be inspired forcibly after a normal inspiration. Our answer is inspiratory reserve 2,700 to 2,800 ml. Volume of air corresponding to TB plus IRV plus ERV is vital capacity 4,800 ml.
Number 6. Record experimental respiratory volumes as determined in the laboratory. Average TB 300 to 500 ml. Average ERV 700 to 1,200 ml. Average BC 1,200 ml. Average IRV 1,900 to 3,300 ml.
Factors influencing rate and depth of respiration. Number 7. Where are the neural control centers of respiratory rhythm? Medulla oblongata and pons. Base of pneumograph. Reading of respiratory variation. What was the rate of quiet breathing? Initial testing 12 to 15 breaths or minutes. Record observation of how the initial pneumograph recording was modified during the various testing procedures described below. Indicate respiratory rate and include comments on the relative depth of the respiratory peaks observed. Talking. Respiratory rate becomes irregular during talking. Yawning. Yawning is reflected by extremely deep, prolonged inspiration. Laughing. Respiratory rate becomes irregular. Respiratory dip may be increased or decreased depending on the nature of the laugh. Standing. Regular rhythm and rate. Running in place. Increased rate and depth of breathing. Swallowing water. Respiration ceases during the period of swallowing. Coughing. Respiration rate becomes irregular and marked by expiration during coughing. Lying down. Regular rhythm and regular or slightly depressed rate decreases. Concentrating. The respiratory rate is irregular unless punctuated by intervals of apnea in individuals who hold their breath when concentrating. Student data. Breath holding interval after a deep inhalation 10 seconds. Length of recovery period 15 seconds. Breath holding interval after a forceful expiration 7 seconds. Length of recovery period 10 seconds. After breathing quietly and taking deep breath, which you held, how did you feel an urge to inspire or to expire? Our answer, expire. After inhaling and then holding your breath, did you want to expire or inspire? Inspire. Observation after high ventilation. Oxygen increases, CO2 decreases.
Number 11. Blood CO2 levels and blood pH are related. When blood CO2 levels increase, the pH increases. Explain what changes might occur in the blood pH if the breathing rate increased or decreased. Our answer is the blood carries carbon dioxide to the lungs where it is exhaled. As the carbon dioxide accumulates in the blood, the pH of the blood decreases. For number 12, length of breath holding after hyperventilation. Our answer is 12.3 seconds. Next is why does hyperventilation produce apnea or a reduced respiratory rate? Our answer is hyperventilation washes carbon dioxide out of the blood. Since carbon dioxide is the major chemical stimulus for inspiration, the desire or drive of breath is decreased. For number 13, observation of rebreathing breath air. Our answer is more oxygen and less carbon dioxide. Next is why does rebreathing breath air increase the respiratory rate? Our answer is the CO2 exhaled accumulates in the bag at a level greater than normal air. This stimulates increased force rate of respiration. For number 14, the following factors generally increase indicate with I or decrease indicate with T, the respiratory rate and depth. So for number 1, increase in blood CO2. Our answer is I. For number 2, decrease in blood O2. Our answer is I. For number 3, increased in blood pH. Our answer is D. For number 4, decreased in blood pH. Our answer is I. Next is, did it appear that CO2 or O2 had greater effect on modifying the respiratory rate? Our answer is CO2. For number 15 or the last number, where are sensory receptors sensitive to changes in O2 levels in the blood located? Our answer is it is located in the aorta or the carotid artery.
Hi once again, I am Zon Khyze M, one of the reporters for Test 3 Respiratory Care Modalities. So the first picture provided is called as nasal cannula. It is a lightweight tube that's connected to an oxygen supply on one end. On the other end are two prongs that are placed in the nostrils. A nasal cannula is considered a low-flow system that mixes oxygen with the air in the room, providing 24 to 44% oxygen. Its max allowable O2 concentration was 20 to 40%. Flow 1 to 6 L over min. The indications for the use of HFNC in adults include community-acquired pneumonia, post-extubation, even in low-risk patients, pre-oxygenation prior to intubation, DNI patients with respiratory failure, and perhaps in patients with cardiogenic pulmonary edema when NIPPV is not tolerated.
In the second picture, our answer is Faye stent. Description: a Faye stent is a shield-like device that fits under the patient's chin and encircles the face. It is used primarily for humidification and for oxygen only when the patient cannot or will not tolerate a tight-fitting mask. The port on the corrugated tubing or base of the mask sets the oxygen concentration, delivers humidified oxygen for patient comfort. Indication: Faye stents are used to provide a controlled concentration of oxygen and increase moisture for patients who have facial burn or a broken nose or who are claustrophobic. Max allowable O2 concentration 28 to 100%, flow 8 to 12 liters. In the third picture, our answer is simple face mask. Flow 5 to 8 liters. Max allowable auto concentration 40 to 60%. Description: a simple face mask is usually used to deliver a low to moderate amount of oxygen. A simple face mask contains holes on the both sides to let exhaled air through and to prevent suffocation in case of blockage. It can deliver around 40% to 60% oxygen to 6 to 10 liters or minutes. Indication: the simple face mask or SFM is a basic disposable mask made of clear plastic to provide oxygen therapy for patients who are experiencing conditions such as chest pain, possible heart attacks, dizziness, and minor hemorrhage. Fourth picture, our answer is partial rebreather mask. Flow 6 to 10 liters. Max allowable auto concentration 50 to 70%. Description: a partial rebreather mask is a mask that covers both nose and mouth. It has one two-way bulb connecting the mask and the receiver bulb. The two-way bulb allows about 1/3 of exhaled air to get into the bulb. The 2/3 or exhaled air not getting into the bulb flows into the atmosphere. Indication: they are useful in situations when people have extremely low levels of blood oxygen. Since they can quickly deliver oxygen to your blood, a partial rebreather mask looks similar to a non-breather mask but contains a two-way bulb between the mask and receiver.
So, good day everyone. My name is Ellaiza Fronteras, and this is the continuation for oxygen delivery system. The first is device non-breaker mask, a device used in medicine to assist in the delivery of oxygen therapy. So the max allowable oxygen is 60% to 91%. The L per minute is 10 to 15. So the indication for use is used in emergency situation to prevent hypoxemia, also known as low blood oxygen, conditions that disrupt your lungs' ability to uptake oxygen or your heart's ability to pump blood can cause low blood oxygen level. The next is breathing circuit. Breathing circuit is a medical device used to deliver oxygen, remove carbon dioxide, and deliver inhalation anesthetic agents to a patient. So the max allowable is 17%. The L minute per minute is 5 liter per minute for children up to adults. So indication for use is gases required the patient's expired carbon dioxide to be removed to prevent hypercarbia. This is accomplished by means of a CO2 absorbent contained in a housing called an absorber. The breathing circuit absorber must allow the use of both automated or machine ventilator and manual breathing circuit valve ventilation. Most present-day absorbers are standalone sub-assemblies that tie into a related function of the machine. They are modular and can be exchanged easily if needed. They are the union between patient and machine and are where respiratory gases mixed with fresh gas flow from the machine. The next is transtracheal catheter. Superior method of delivering oxygen directly into the lungs through a small flexible catheter that passes from the lower neck into the trachea or windpipe. So the max allowable is 50 to 75%, and the liter per minute is 1 to 2. Transtracheal oxygen therapy is a method used to deliver oxygen directly to the lungs. It is used to treat chronic hypoxemia or low blood oxygen. A small plastic catheter is surgically placed in your neck and it sits in your windpipe or the trachea. Oxygen is delivered through the catheter directly into your windpipe. The last one is nasal pillow mask, a type of CPAP mask consisting of plastic inserts that look like a headphone earbuds that slip directly into the nostrils. The prescribed pressure used to keep the airway open is delivered through this mask. So the max allowable oxygen is 70 to 100%, and the little per minute is 10 to 15. Patient wear a CPAP mask during the night over their nose and mouth. The mask connects to a small machine with a hose. The machine pumps pressured air into the patient's airway to keep it open while they're sleeping. Continuous positive airway pressure is a type of treatment proven effective for sleep apnea.
Hello everyone, I am Victorianne Gapasin, and I will discuss the answers for Part 2, Oxygen Tank. First, identify the parts and the purposes of such parts presented in the picture below. Number 1, we have oxygen gauge. This measures oxygen left in the tank. Second, flow rate. Controls the rate of the oxygen comes out of the tank. Third, flow control valve. It regulates the flow rate of the oxygen. 4, cannula tubing. It is used to deliver the oxygen in the airway. 5, humidifier bottle. It is to warm the oxygen to prevent airways from becoming too dry. 6, oxygen tank. This keeps the oxygen under pressure and it also serves as storage for the oxygen. What are the indications and contraindications of oxygen therapy? Oxygen treatment is contraindicated in all patients with unfavorable ventilation response to oxygen treatment. In case of non-effective oxygen treatment, mechanical ventilation must be turned to, as well as in all cases with patients in respiratory coma. What are the nursing considerations for oxygen therapy? First, the nurse must identify the need for oxygen therapy by the physician or hospital policy. The second step is to conduct respiratory assessments on each patient to determine the level of oxygen therapy and titration protocol, and to document the results appropriately. Third, explain to the patient the importance of oxygen titration in accordance with the physician orders or hospital protocol. Finally, to avoid hospital-acquired pneumonia, encourage the use of incentive spirometry every hour.
Good day everyone, my name is Monica Guinocor, member of Group 4 in Anatomy and Physiology subject, and the representative to demonstrate the procedure called Assessing the Respirations. Now we are going to have an assessment which is to assess the respirations per minute and the possible nursing diagnoses, which are number 1, fast irregular respirations, and number 2, slow irregular respirations. And now, let's get started! Now, the first thing that we have to do is to perform hand hygiene. This is to reduce the risk of infections. And also, we should ensure the patient privacy. So this is my patient, and the next thing that we have to do is to introduce self and verify the client's identity using agency protocol. Good morning, ma'am. My name is Monica Guinocor, and I will be your nurse for today. May I see your ID band, please? So, can you tell me your first name, last name, and your date of birth? I, Guinocor, October 27, 2005. Great. Now, ma'am, I am here to assess your respiration rate, and I want you to participate as you do what I say because this is necessary to monitor if you have normal breathing or if you are using any accessory muscles or just to identify if you have any underlying medical conditions that needs to be given immediate care right away. So, is it okay if we start now? Yes, ma'am. Great. Now, the next thing that we have to do is to check the factors that can affect respiration, such as exercise, anxiety, acute pain, smoking, and medication. So we are going to ask our patient, do you have an anxiety, ma'am? Acute pain? Do you smoke? Do you have any medications that affects your breathing? Did you do exercise minutes ago, ma'am? Great. Now, what I want you to do, ma'am, is I need you to sit comfortably and I'll get your respiratory rate. Okay, ma'am? Now, help your patient into a comfortable position. It could be sitting or lying with the head of the bed elevated 45 to 60 degrees. But because our bed cannot be elevated, I will just let my patient sit comfortably. Make sure his or her chest is visible. Ma'am, will you please sit comfortably? You. It is much better not to let your patient know that you are counting their breathing because they will alter it or they will change the way they breathe. If you anticipate it, we will place your arm in a relaxed position across his lower chest or upper abdomen as you would to assess your pulse. Place your hand against the client's chest to feel the chest movements with the breathing and observe the chest movements while supposedly taking the radial pulse.
Complete the respiratory cycle of 1 inspiration and 1 expiration, then look at your watch. When the digital paces reaches a round number, begin taking the respiratory rate counting 1 with the full respiratory cycle. If the respiratory rhythm is regular, count it for 30 seconds and multiply the number of breaths by 2. The respiratory rate normally ranges from 12 to 20 breaths per minute. If the respiratory rate is irregular or at less than 12 or more than 20 breaths per minute, count the breaths for a full 60 seconds. As you count the rate, note the depth of the respiration by observing movement of the chest wall or do this after counting the rate by palpating chest wall excursion or auscultate in the posterior thorax. Describe the depth, may be shallow, normal, or deep. Also know the respiratory rhythm, which should be regular or irregular rhythm. Observe the character of respiration or the sound they produce and the effort they require. Observe for dyspnea or the difficulty in breathing, where the patient gasps for air.
And lastly, discuss your findings with your patient. Now, have you had any breathing problems? Okay, so your breathing rate or your respiratory rate was 16, which is within the normal range. Now, I'm gonna get you in the position that you were and let me know if you need anything, okay? And that ends our video for today. Thanks for watching!